Hello, Dr. Gary Swift. Thank you so much for talking to me today.
My pleasure, Christine.
Dr. Gary Swift, what is laparoscopic surgery?
Christine, laparoscopic surgery is a method of operating where we use small incisions with the intention of causing less pain, short hospital stays, less analgesia use, but to achieve the same sort of things that were achieved medically through large open operations in days gone by. The benefit, as I said, to the patient particularly is cosmetic, particularly comfort-wise, return to normal duties. So the number of operations we've been able to do in the last 20 years or so has expanded greatly. The techniques we've got have developed also, and the ability to, as I said, do the same operations that were done with large open incisions, long stays, a lot of discomfort, big scars have now been replaced by this keyhole surgery.
And what conditions can be treated with keyhole surgery?
In the gynaecological field, which is where I operate, there's a host of conditions that we can treat. And probably the number one condition I personally treat is endometriosis, which I've gone into on another sort of short clip. But also endometriosis particularly is a condition where there are deposits of the line that are the same as the lining of the uterus that grow outside the uterus. And that scarring or distortion is ideally treated by removing the abnormal disease deposits. So endometriosis is probably the number one condition. It affects about 8 to 10% of women. Ovarian disorders, particularly benign ovarian disease, and common things like cysts or benign tumours are best treated laparoscopically. We've got the instruments and techniques to be able to dissect abnormal lesions out of ovaries, to suture ovaries back together, so to preserve ovarian function. And we have special instruments also to allow us to remove large cysts through special bags so that we can still remove the actual tissue after decompression through small holes. Sometimes obstructed or damaged tubes, we can undo the adhesions with special instruments through a laparoscope to restore fertility. Sometimes if some tubes that may be blocked can be suitable to be unblocked, again to restore fertility. Sometimes when pregnancies are actually ectopic or caught in the tube, we've got to put the telescope in and actually take out the pregnancy or sometimes even the tube, and that's probably one of the emergencies we use laparoscopic surgery for. There are also tumours that grow in the uterus called fibroids. Now they're almost always benign, but fibroids enlarge and distort the uterus, can cause heavy periods, can cause pressure or mass effects on the uterus, and we now have techniques when we can take even quite large fibroids up to 10 centimetres in diameter with a device called a morcellator, which actually reduces the size of the specimen and pulls it out in small fragments. So large procedures, large benign tumours can be removed through laparoscopes as well. It is also possible to take the uterus out or perform a hysterectomy through laparoscopic techniques, and there are most of us who think that this should be the gold standard for hysterectomy. We think the days of large incision surgery should be behind us. There are always a small number of women where the uterus is so large that it's not physically possible to do, but as a technical procedure, there's certainly a lot to gain. Women are in hospital for barely 48 hours. The return to normal is very rapid. Most women can do most things within 2 or 3 weeks. Although the healing process still takes 6 weeks on the inside, sometimes it's more of a challenge to slow women down after these sort of surgeries to allow their bodies to heal. And there are some other procedures which are variations, some prolapse or pelvic support surgeries done with the aid of laparoscopy as well. So there's an ever-expanding list of procedures that are possible. And as we get techniques where we can suture through small incision holes, once we get instruments that help us retrieve specimens and to actually seal off blood vessels, and there are companies that are constantly developing new equipment to increasingly expand our range of surgical options.
Gary, what happens during keyhole surgery while the patient is asleep?
Right, so the one thing you have to have to do a laparoscopic procedure is a general anaesthetic. So you need to be asleep. So most people don't want to know what happens when you're asleep, but in reality what we've got to do is position correctly. But with women we put them in what's called a Trendelenburg position, so the head's actually down, so they're tipped, so the bowel actually falls out of the pelvis so we can see the pelvic organs clearly. We often use a little instrument to manipulate the uterus, because the uterus is not a fixed organ, so sometimes we need to look behind it or beside it or use other instruments to actually move it away. A lot of women, particularly if they've got menstrual disorders, will need a little procedure called a hysteroscopy at first, where we look inside the womb and then we put a little instrument so that we can help manoeuvre the womb into position forward or back. Then there's a small incision made in the umbilicus or the belly button, and that's usually about 1 centimetre, and we try and do that right in the base of the umbilicus so you can't actually see the scar once the procedure's finished. And through that goes the main port, or what's called where the telescope goes through. And once we see that we're safely into the abdomen, we attach a gas line. Carbon dioxide gas is infused into the abdomen at a predetermined rate with a maximum pressure so that we don't cause any harm to any other organ systems in the body. And then once the abdomen's distended with the carbon dioxide gas, we put various other small ports in. Our lateral ports are usually 5 millimetres in width, so they're small. Most laparoscopic instruments are 5 millimetres diameter, and we use those ports, as they're called, as access points to put instruments inside the abdomen. The fourth port, or the suprapubic port, depends on what size specimen we're retrieving. If we've only got multiple small specimens, we'll use another 5 millimetre port. If there's a large specimen to retrieve, then we need to use a larger port, and up to a 12 millimetre, but we're still an incision that's barely more than 1 centimetre across. And that's also the size port we need when we're doing what's called laparoscopic suturing, when we've actually got to put sutures in and out of the abdomen. That morcellated device I mentioned to help remove fibroids is very slightly bigger, but we can fit a morcellator through a 15 millimetre incision and then take out a lump that's 10 centimetres in diameter. So the mechanics obviously are very much in favour of keeping the incisions very small.
Are there any possible complications?
Look, Christy, every surgical procedure has risk and complications, and it would be wrong to say that every operation that's performed is completely safe. But in reality, serious problems are extremely rare. And we would tell that women undergoing what's called operative laparoscopies that the chance of an unintentional injury, so damage to the bowel, bladder, blood vessels or ureters, little tubes from the kidneys to the bladder, is in the region of 1 in 500 to 1 in 1,000. So it may be increased slightly if there's other diseases that distort the anatomy or make things abnormal, but it's very, very low, and we take every possible care not to cause any harm as a standard approach. Nuisance problems like bleeding, scarring, wound infections and healing problems are again rare, but they're not zero. When we say, generally speaking, about 1%. And most of us who do this sort of surgery would give what's called prophylactic antibiotics to minimise infection risk. Mm-hmm. We make sure that calf compressors and all the things that we can do to help prevent problems in advance are taken. There are women who we give sort of bowel preparations the evening beforehand, so the bowel is actually empty and out of the way, so it helps us for access, but also minimises the risk of bowel injury. And that's particularly important if the bowel might be involved in a disease process or adherent to an ovary or an endometriotic deposit. So most of us have a very low threshold to take the steps in advance to minimise or prevent these problems. And of course, if a problem does occur, although it's rare, then it's important we take whatever steps we need to manage it correctly and make sure there's no long-term harm. So ultimately, very safe surgery, and the chance of anything going seriously wrong is incredibly rare.
What should be expected regarding recovery after the procedure?
Most of the operations that we do laparoscopically are overnights or same-day stays. So even the large fibroids I spoke of, even most cases of endometriosis, and a lot of significant sort of ovarian cysts and lumps and bumps stay in hospital less than 24 hours. There are a lot of trivial diagnostic procedures which will go home same day, and even the laparoscopic hysterectomies, which are often the more complex procedures that we do, and a lot of them can go home within 48 hours, occasionally a day or two longer, but the vast majority of patients are suitable for discharge within 48 hours. Now that doesn't mean that there's still a period of discomfort at home, but daily functions like normal moving around the house, going to the toilet, doing normal things is possible without significant discomfort. And we don't send you home without anything, but also send you home with often anti-inflammatories or analgesics that we think are in proportion to what we've done to you. So, and recovery varies. Most women, I would sort of say, with straightforward surgery will be doing most things the following week. Hysterectomies, as I said before, sometimes we've got to slow women down and say, take it easy, let your body heal. So because they don't have incisions, they want to do too much too soon. So it's a case of slowing things down. But again, there's always a bit of individual variation. There are always some people who wake up from anaesthetics a lot better than others. So we've got to factor in quite a variability, as with most things with human beings.